So out of pure incompetency of my own abilities, I have brought Suzanne with me today so that you can compensate a bit. We work at Bergman Clinics. Let me do a quick introduction and then hand over for more of the content to Suzanne. I'd like to give a bit of a helicopter view of what is our company and why this might be interesting to you. Is not because I would like you to join us or something else, but to give it a bit of context. We are Bergman Clinics, a focused healthcare clinic system in Northern Europe, as we say, Netherlands, Germany, and a bit of Scandinavia. We focused on plannable care. We started out as a cosmetic care provider, actually in a shed somewhere in a small village in Naarden, but over the years have become, I think, the cross-country leader, especially in ophthalmology and musculoskeletal. But the care that we provide does not include an emergency room. We don't have many overnight stays. We focused on plannable things. So we're a bit of the factory of healthcare. We do that with quite a big employee and patient base. A couple of facts on the right you can all just read up on. One of the challenges that we see is that, we see a very big gap in what have been historically proven to be, let's say, the pitfalls of any digitization. And now this new wave of artificial intelligence, automation, robotization, standardization is coming our way. And we find ourselves a bit anxious to not step into the same traps as we did before. And I think if you look at any random consultancy probably has a report like this hanging around, 80% of all of the digital pilots in healthcare failed to make it to anything scalable. Only a couple of the partnerships that were, hugely broadcasted and maybe even marketed were actually successful. And we want to just make sure that this next wave of growth is not hitting us in the head, but we're actually trying to surf it and progress with it. As a bit of background, Bergman Clinics started with the wave of growth throughout the, let's say, mid-2000s, and it's still continuing where we inorganically expanded. So we bought a lot of clinics across all of our divisions or across all of our specialties. But it's quite fundamental to understand that if you buy a clinic, an individual clinic, that is usually run by a physician who has his or her own standards. A small team that helps him or her. So that means standardization has always been at the core of what we do. So when we buy a single clinic, we tell them you can remain at this location, or you can do that, you can keep this, and that. But some things will have to change. There will be a standard process of planning a consultation. There will be a standard tool that you need to report into. We do use this EMR and those kinds of things. But management has always remained quite clinic by clinic, which is we don't have one building or a hospital. We have many different clinics in many different locations with all mini CEOs ruling those individual clinics. The second wave that we've gone through was to optimize basically and optimize on a scale level. So procurement is one of the first things that you usually find. Buying new knee implants is a good case to drive value and also standardize and harmonize, and actually also start forming those partnerships with suppliers. If we do the most knee implants in the whole of the Netherlands, how can we, together with our suppliers, make that process even more valuable and the outcomes even better than before? At the foundation of that, and I think it's quite small in that little house there, is something around data. We already started building some of these data processes quite early on because we wanted to understand why is a process different in this clinic that we just acquired. And if it's better, why don't we do it at all of our clinics? Or if it's worse, how can we convince the new clinic to actually transfer to this new process flow? And what we see now is that we continue those waves of growth, but our third wave of growth is really looking at the integral care path. I think it's one of the buzzwords that everybody's been talking about, but if you look at how to grow, then the first wave is just getting bigger. The second wave is, tweaking the engine a bit, but now we're really looking at, we're doing something different. I can tell my ophthalmologist to, instead of take 13 minutes for a cataract surgery, make it 12 and maybe even 11. but at the end, there's just a physical limit of how fast a lens can get inserted into an eye. We will never get 0 minutes, and it will never get one minute. So that's why we're looking at a care path and thinking, but what if we cut some steps from this process? Maybe if we hand back responsibility to the patient, maybe if we can automate things or digitize things, how does that work? And it's a completely new way of looking at it. We find ourselves ambitious, but also sometimes a bit trapped in complexities, in which I think Suzanne will tell you much more about. Let me step outside of the green zone.
So here you see in one slide what we do, how we do it, and what our proposition is. So we have shorter waiting and response time, better market quality and prompts, and lower cost per treatment. And what we do is the best-in-class medical content. That's, of course, a treatment. For example, we push little pieces of information to the clients at the right moment. And excellent operational processes, the delivery, getting all the waste out of the processes and getting better in it every day, step by step. Strong back office organization, the support. Think about smooth processes, automation, that the doctor can really focus on the client. And how we do it, we are creating uniform data sets to really make targeted decisions and measure them. We have clear governance and ownership. That's, of course, a steering. Think about an owner of a care pathway. Think about cross-functional teams. And creating a learning environment, the improvement, setting up pilots, learn fast about if it's scalable or not. If it's not, cut it down, and otherwise scale up. So where do we start with development? It's always good to have the bigger picture in mind. But don't get too much stuck on the order or the end state. Just get started and preferably get started small and low key. So this is a use case we are working on right now. It's for the dermatology, and like the main goal is that first the client. We try to like a dermatology. We try to the first consultation. We try to the client that is not coming to the hospital for every first consultation, but instead we ask them to upload photographs, and those photographs are assessed by a doctor, and the end result can be immediately planned treatment, or a prescription, or even no action at all. What we try here is that we start, and of course you can imagine that you can digitize it by pushing the photographs immediately to the EMR, get it maybe by a automated triage. And if we are mature enough, you can understand that maybe we can embed IA in it, EI, because of then you can, for example, suppose a sort of diagnose to the doctor. But here we start small and low key, low tech. We ask the client to before the booking of the first consultation, we ask the client to upload some photographs, and those emails, they are linked with the practitioner, and the practitioner assesses those photographs and gives an outcome. And so what we want to say is that start small and low tech to quickly learn, and if you are and just go step by step, not have the end goal, of course, in mind, but start small, low key, so you can learn about the scalable solution, and if it's really has a future. Yeah. So here we have an example of a uniform data set we are creating. You're looking at the care pathway of cataract. And if you look at the left, you see one care pathway from one variation with about like 1,600 people went through it. And you see like an optimal outcome, and the optimal outcome is the perfect combination between the medical results, client satisfaction, and efficiency. And you see a 9, and you see that it takes about 2.5 months to go through it, the average of it. If you look to the right image, you see like more than 26,000 people run through it, but you see more than 6,000 variations of a care pathway of cataract. And you see like an optimal outcome of 8, and you see that the run-through is 4.5 months. So if you know this, if you have this insight, you can, of course, steer towards the left one and try to get the right things in place to get there. And as well, this gives as well lots of insight into how processes run, officially and unofficially. And if you want to implement functionalities in the running business, it's very important to have insight in all these different kinds of official and unofficial processes. So the 4 categories of the data-driven impact: better decision-making, evidence-based, identify trends. Think about that a trend that you can identify is, for example, that you see a lot of cancellations of surgeries just before the intake. And that can be, of course, like a risk that surfaces only just then. So an action, what you can take is, if you identify the trend, the action you can take is, for example, implement a pre-op questionnaire, so you can be ahead of that. Enhance customer compliance. Personalization, customer journey mapping. So if you have a customer journey mapping, you of course can identify where the big impact lies. And if you talk about personalization, think about a care pathway that fits age, fits diagnosis, maybe lifestyle, and maybe pushes reminders to you on that level. Increase the efficiency. Think about process optimization, resource allocation. For example, when at busy days, make sure that a lot of doctors are scheduled, and improvement performance and track KPIs. Think about, we just implemented a questionnaire, a digital questionnaire, and we can track that it's improving the turnaround and maybe reduces admin burden. So when you have all that insight, we can still scale those in 3 ways and embed in the end AI. So we can scale through maturity, and then you have to think about process optimization, think about adding new functionalities to it. We can scale them through reach. So is the solution scalable through multiple business units? Can we enlarge it through more care pathways? can we add more users to it? And as well, technology. Of course, first we start with just the human, then we automate stuff, and in the end, if we are mature enough, we can add AI as well to it. But it's quite important to define those criteria of scaling up upfront. So you're ensuring that you're making impact, but as well that if the team thinks we have to accelerate and it's time that we can go, and that you don't have to go back to the board for approval again.
Yes, this is where maybe the boring part comes a bit, but I'm really passionate about this boring part. I think, standing here at this conference, looking at the exhibitors in the hall, knowing that there's an AI part going on in the other room as well, I think technology is really already there. Also reflecting on the talk from Tuomi just now, on these doctors probably know that in 5, 10 or 15 years, their day-to-day routine will be very different. For me, the hardest part of doing anything in healthcare, I also tend to slip in that my wife is a doctor, so I kind of know the complexities of working with doctors quite intimately, is that the steps towards that are very often much harder than actually painting that end picture. And as Suzanne just said with our dermatology case, everybody understands that in a couple of years, you just take a photo, you find out what it is, and we'll get the treatment done. But until we get there, there's so much stuff that we need to cover and so many walls that we need to break down. So I'm passionate about technology, but I'm also agnostic about the fact that you will always find a tool that does 99% of what you want it to do. It's about the people that you need to get on board. So reflecting on what I found in Bergman, but also knowing that we have an ambitious board, an ambitious ownership that wants us to push further, I think I tend to speak a bit more about, what do you really need to get right in order to get this done? And I always start with, the biggest quote that we've all heard: multifunctionary or cross-functional teams. It sounds so easy, but to really have somebody laying that picture out of that care path, showing it to a doctor, saying, look guys, you are the cataract specialist in our company, whether that's in the Netherlands, Germany, Norway, I don't care where you're from. You know medical profession much more than any of us does. But if you treat out of the 45 to 50,000 patients in so many different ways, then it's impossible to standardize, and you need to standardize in order to digitize, in order to deploy technology, in order to do all those kinds of things. And in the first meetings, it will be very, very awkward. Like a data guy is actually looking at a doctor, who's looking at a nurse, who's looking at an operational consultant, thinking, what the hell are these people going to tell me? But after a couple of these iterations and sessions, you can really start seeing people learning from each other. And also, instead of pushing information or being a bit resistant, asking stuff like how do they do that? How does the other location do that? How does the other doctor do that? What is another form of driving value, better patient quality? This little metric that we had on the bottom left, showing a 9 of the optimal outcome versus an 8. What drives optimal outcome? How can we influence that? How can I influence that as a nurse versus a clinic manager versus a doctor? It's very interesting to see. And I always like to talk about the things that you then have to, the tough decision that you need to make. So it means if we're starting a program that goes about any digitization, any transformation, whatever buzzword you want to connect to it, we need to mandate full commitment from all of those people involved. I'm not going to digitize without the doctors. I'm not going to digitize without BI, business information systems, not at all, not without any of the operational responsibles. The second is, and it sounds so easy, but once again, deploy a learning mindset. Coming back to the dermatology case, everybody knows that that's going to be the end case. And everybody has their own vision of how that looks like. But if everybody's very stuck on that single vision that they have, nobody's going to get anywhere. The example I sometimes take is that when people are referred, so in the Netherlands you go to a GP, you get a referral to get a treatment at Bergman. One of our visions was that every patient would get an automatic referral planned, like within seconds. And I get it. super nice, but it also means that I'm in Frankfurt right now. If I would get a referral, I will be planned in 5 minutes somewhere in Western Holland to do my appointment. Doesn't really work. So whoever pitches this as the final idea needs to also understand we're going to learn. Like, do we need to first do something else to the process? Make the patient make their own appointment first for the first 3 days and then give them an automated appointment? Or do we need to make the patient fill in something before they get that automated appointment? The process that people have in mind often on a very highly aggregated level sounds the same, automated appointments. But when you really dive into that, there's so many sidetracks and things that you need to deliver, things you need to overcome, that if you deploy a learning mindset and really understanding the process, it's fundamental to what you do. Which also means that I, and maybe the board of our company as well, needs to give that freedom to those teams, right? If you say you want a learning mindset, it means that people are actually allowed to learn. Sometimes it's a bit clear to what I say, but that means that you do not set on an individual outcome. You don't define the outcome process. You define the result of that process, and the teams will find their way to it. One of the other things that I found is also very interesting is we're a private-owned company. So that means we have a board and we have investors. In this case, it's a private equity investor. If you want to deploy a cross-functional team that gets together in a certain cadence and that gets to learn in these waves, it's of no use to have quarterly updates that take a week to prepare, take a week to digest, and take another week to put all the actions back into the organization. If you're going to go for a learning environment with multidisciplinary teams, that's your cadence. Stick to it, because otherwise people will be very frustrated to fill in another Excel template about what we've learned, because that's not the way it works. And I think lastly, it's about team ownership and decentralized authority. You can only learn if you actually control things yourself. If you're allowed to learn within a technology domain, within a process domain, within something, it's super important. Acknowledging healthcare, we have medical rules, right? We can't just start operating cataracts in a different way or putting different prostheses into knees. But this is really where I think the acceleration of the program goes to, of any change program goes to. So try to challenge yourselves, and I try to challenge myself as well, to not escalate decisions up, but push them down. If you're learning about the process of a cataract surgery and you have a question, usually the answer is somewhere down in the organization, not up, because they will have an even more aggregated level of understanding what's happening. And really use whatever meetings you have, whatever come-togethers you have, to also create a positive vibe about what you've learned and why that is important, and give that to the teams. So a couple of things that I think I'd like to show, and I know this is a bit of a cheesy final slide, but it's very important for me to give you these lessons, because that's what I usually take out of these sessions myself. The first one is defining your patient journey, your care path is the way to go. It's probably one of the only ways that you will cut out slack from your system. And it's not about people, reducing people or making more profit. It's about making our very competent healthcare professionals do the right things. I have the same thing in my job, right? I need to do some things that I don't like myself. I need to approve vacation days for my team. I need to reply to assistants who have questions about meeting rooms. Killing those things for our doctors, for our nurses, for any healthcare professional is the way to go. And the only way to think about it is, what is a care path? How does that work? Drill it down to, in the end, maybe even a daily routine for a doctor, but that's the way to go. Don't bother too much about doing the right thing first thing right. It's more about generating momentum, finding where the appetite is in your organization. Is it one doctor that is willing to copy and paste AI results from a text note thing into the EMR and then moving it back and forth? That's your proof point. Go and build on it. Whether you think the value is somewhere further down or further up in the care path, it doesn't really matter. Go with the momentum that you have and build on that. Steering that is easier than accelerating or stopping it. I used to say don't put lipstick on a pig, but apparently that's not a very nice expression anymore. So I'd say that no digital lipstick on analog problems. Really understand what you're trying to digitize. If somebody is coming to you with a super cool idea, break it down. Like, do we really understand what is going on in this process? Do we understand why this doctor is spending 7 minutes doing this, or why this takes so long? And then, get a digital solution in place. From the limited experience that we have at Bergman with AI, and we've done numerous pilots, and we've seen what it can do, as long as you have the data quality and something of the information, plus the process and the outcomes clear, you can deploy AI. If any of those three is unclear to start with, the first lesson was, start. Do not wait for doing the right thing. But if any of those three ingredients is not really clear up front, I'd say raise not a red flag, but an orange flag, and start thinking about why do you really want to do this? What is the outcome? Also, coming back to Suzanne's point, you need to define the criteria to scale up front. So that means if we don't have more cancellations of appointments, then we scale to new locations or whatever. That is your outcome. That's what you want to go for. But do plan for scale from day one, right? So manual processes, pilots, those kinds of things are fun to do, but make sure you always know what the trajectory is towards that full automation and scale. And lastly, but I think many of us can talk to that. Really empower those teams. So if you give them a problem, let them solve that problem. Let them not escalate every time that they run into a small complication or a small deviation. Empower them to do the right thing. That's where I think I'd like to end it. Hand it back to you, I guess, Suzanne.
Thank you, Robert. Really appreciate